Effective treatment requires knowing what actually causes the clinical outcome. A biomarker correlation tells you that the marker moves with the outcome. It does not tell you that changing the marker will change the outcome. Correlation tells you that two things move together. Causation tells you that changing one will change the other. Only intervening on the true causal pathway produces the intended clinical effect. Intervening on a correlated biomarker that is not the cause does nothing to the patient's trajectory. The outcome is determined by its causal structure, not by what happens to covary with it. Treatment without a causal model is not evidence-based medicine. It is guessing with a measurement. A causal pathway model assigns each clinical variable a mechanism. Each outcome is determined by its causal drivers and by patient-specific variation that is independent across patients. The mechanisms encode how things work, not simply how they happen to move together in the data. When a physician prescribes a treatment, they replace the natural mechanism for one variable. They set that variable externally, for instance, by controlling drug concentration, severing its dependence on prior causes. The rest of the patient's causal structure is unchanged. This is what makes treatment different from simply observing a patient who happens to be in a different state. Intervention disconnects the target from its natural causal parents. Observation does not. Identifiability asks whether the true treatment effect can be recovered from routine clinical data without running a controlled trial. Even without a randomized experiment, this is sometimes possible. It requires that all pathways through which confounders influence the outcome can be blocked by conditioning on measured variables. When such a blocking set exists among the recorded patient data, the treatment effect is identifiable. The calculation uses only the observed distribution. No trial is needed, the causal structure does the work. But identifiability is not always achievable. It depends on the causal structure of the disease and on which variables were actually measured. The answer changes when the measurement set changes. A hidden clinical confounder is a factor that affects both which treatment a patient receives and what their outcome will be, but is never recorded in the chart. Disease severity not captured in structured data is a typical example. A more severely ill patient may both receive more aggressive treatment and have worse outcomes, for reasons that are never observed. Because the confounder is unobserved, it cannot be conditioned on. The backdoor pathway it creates through the causal structure cannot be blocked. In this case, the treatment effect cannot be recovered from the observational data. No statistical method removes bias from a factor that was never measured. The only reliable solution is a controlled trial where treatment assignment is external. Without that, the true causal effect remains opaque. Consider a clinical trial that targets a biomarker correlated with patient outcomes. The biomarker improves. The patient outcomes do not. This is the fundamental failure mode of treatment designed from correlations alone. The biomarker has no causal pathway to the outcome. Setting it to any value, low, normal, high, leaves the outcome distribution unchanged. A target indicator can be moved without moving the underlying disease process. Because the indicator is not the cause. Causation, not correlation, determines what clinical intervention can achieve. Moving a symptom is not the same as removing a cause. Effective clinical control requires three conditions to hold simultaneously. First, a correct causal model that identifies the true treatment pathway. Second, a treatment effect that is identifiable from available patient data. Third, sufficient physiological reserve. The patient's organs must have enough remaining capacity to respond to treatment before reaching an irreversible threshold. If any one of these three conditions fails, clinical control fails. Treating a non-causal biomarker fails the first condition. An unmeasured confounder in the data fails the second. A patient already at organ failure fails the third. The three conditions are not redundant. Each one is separately necessary. All three must hold for treatment to produce its intended effect.